right, I just wanted to welcome everybody to today's seminar on Michigan Opioid Prescribing and Engagement Network, Research, Policy, and Outreach. I wanted to introduce our three speakers today. I think they're going to come up here in turn when they are presenting. First, I wanted to introduce Dr. Brummett. Dr. Brummett is an associate professor at the University of Michigan since 2007, where he is the director of pain research and more broadly the director of clinical anesthesiology research. He's also the Associate Chair for Faculty Affairs and serves on the editorial boards for anesthesiology and regional anesthesia and pain medicine. His research interests include predictors of acute and chronic post-surgical pain and failure to derive benefit for interventions and surgeries done primarily for pain. In particular, Dr. Brummett is interested in the impact of a fibromyalgia-like or centralized pain phenotype on analgesic outcomes. He's the co-PI of two NIH R01 grants studying these concepts, which will provide a mechanistic rationale for appropriate patient selection for surgeries and personalized pain treatment plans. In addition, Dr. Brummett and his team study chronic opioid use in the peri-op period and in the pain clinic, including the risk factors of new persistent opioid use, as well as the impact of peri-op opioid use on cost, morbidity, and 30-day readmissions. Dr. Michael Englesbe is here, and he is the Darling Professor of Surgery. He practices transplant surgery here at University of Michigan and leads the medical school's curriculum innovation. His impact interests include broadly improving the care of high-risk surgical populations. And then Dr. Jennifer Waljee is an assistant professor of plastic surgery. Her clinical practice focuses on the care of patients with acute and chronic hand conditions, as well as burn-injured patients. Her research interests include the development and implementation of patient-reported outcomes as quality metrics for surgical conditions and understanding variations in care in reconstructive and hand surgery. Recently, she has applied this interest towards understanding pain opioids and the use of opioid analgesics for post-operative pain control and the development of patient and provider-level interventions to improve care across these domains. So I'd like to welcome all three of our speakers and here today. Thanks.
All right, well, thank you so much. I see lots of friendly faces in the audience today, so it's great to see everybody. My name is Jennifer Waljee, and I'm a surgeon here at the University of Michigan, and I'm going to be talking about a problem that I'm sure many of you have heard in the lay press. It's been all over the media, particularly in the last kind of 6 to 9 months, about the prescription opioid crisis in the United States. And there's an estimate from 2014 that about 260 million prescriptions are written every year, which is about enough for one bottle for every single adult in our country, which is pretty alarming. So the goals of this talk, I'll first kind of give an overview about the opioid crisis in America. I'll try not to, some statistics you probably already heard in the news, I'll try not to overlap on that too much, because what I really want to get to is why is this important for us as surgeons, and how do we get interested, and how can surgeons make a difference in this problem, and in what ways do we contribute. I'll touch a little bit about what we know about postoperative prescribing. We've done some pilot work both in our clinics here at the University of Michigan and then also with administrative claims data, trying to understand the scope of the problem around surgery. And then I'm going to turn it over to my colleagues, Mike and Chad, to talk about why should we care about this in Michigan? Why can we make Michigan the model for the rest of the country? And a little bit about the program that we've put together called Michigan Open. We were thinking about our disclosures and our thank you slides, and we realized that we had far too many people to put on any single slide. So the data that I'm going to present here represents the work of all of us. I will try to acknowledge all the people that worked particularly hard on the analyses that I'll show and the people that collected the data. So thank you to Jaylee, Mitch, May, Caitlin, and Stephanie Moser, who's not here, and Rena, but lots of people. This is a huge collaborative effort, so thank you very much. So unfortunately, in the United States, opioid prescribing is higher than anywhere else in the world. We share that honor with Canada, and about 90% of the world's opioids are prescribed here in the United States. This is a figure from the New England Journal of Medicine that was published early this year in January of 2016. And what I think is really striking about it is it talks about opioid-related deaths, and you can see in red the hot spots, and it looks at it between 2003 up to 2014. So it's clear, even if you can't see the exact numbers, that this is a huge problem that does not look like it's slowing down. We write for prescription opioids all the time in our clinics, and so sometimes it's a little bit hard to tell, well, why should we care about this? And we want to treat patients' pain, and we want to make sure that our patients are recovering well, particularly from surgery. I think that this graph here is also very striking, published in 2016 from the New England Journal of Medicine. While the reasons for which prescription opioids influence heroin use and substance abuse are multifactorial and beyond the scope of this talk, you can clearly see a parallel here with the spike in rates over time. And I think it's also striking to look at the patients in which this particularly affects. This table was drawn from the same article. And you can see that it matters by insurance coverage. And the patients that we care for who are particularly most vulnerable, the patients that don't have insurance or have Medicaid insurance, are at higher risk of opioid addiction and overdose mortality and morbidity related to prescription opioids and also heroin. It's also striking the direct link between non-prescription opioid use and heroin. So about 75% of heroin users are introduced to opioids through prescription medications. So these are medications that we prescribe that people didn't necessarily take and are left around in medicine cabinets and in our homes and are available to use for people that are unintended users. So just thinking where should we start to fix this problem? So who prescribes opioids for care? A lot of it's prescribed in the emergency room. A lot of it's prescribed by our colleagues in primary care, but certainly surgeons are responsible. We prescribe about 40% of prescription opioids. A lot of that makes sense. Surgery is painful, and we want to make sure that our patients are well cared for after surgery. And I'll show in some later slides, though, that the way we do this could certainly be improved. And interestingly, though, despite the fact that we prescribe a lot of prescription opioids, we really get virtually no education about this in our training programs. Those of you in the room that know me know that I completed 3 surgery residencies. This is not a component of any of our educational curriculum. It's not on our board exams, and it's not on our maintenance of certification exams. And so there's not really any kind of algorithm that people have when they get out into practice about what should I prescribe or what should I not prescribe. And the main way that we learn about it in training is based on what the chief resident before told you how to prescribe for, give this patient X amount after their laparoscopic cholecystectomy, or if you're getting feedback from the nurses in clinic, hey, your patients are calling, they need more pain medication, please write for 2 different kinds so that they can have another one to fill, or please write for 90 instead of 60. But it's really, really hard for us to understand, well, what's the person that we're going to write pain medication for who's only going to take 2, and what's the person that is going to fill 5 different times? So how do we know exactly how to distinguish those individuals? Many of us trained, and many of us remember when in kind of the late 1990s and the early 2000s, when pain was considered to be the 5th vital sign. And I would argue that even though that's kind of fallen out of favor and is somewhat controversial, it still pervades a lot of the care climate that we practice in. Patients, if you check into our clinic at Domino's Farms, they're going to ask you what your pain score is when you check in. We ask it all the time in our inpatient care units. And so even though it remains controversial, this concept has not necessarily faded away. We asked surgeons in June of this year at the MSQC meeting, how often do you discuss pain medication with your patients prior to surgery? And only 51% of them said that they did on any regular basis, either most of the time or all the time, which kind of matches up with what our patients say too. We surveyed our patients in the preoperative clinic, and about 50% of patients said that anybody from their surgery care team discussed what their pain management was going to be after surgery. So we clearly fall short in this area. It's also reflected in patient knowledge. So we asked patients in the preoperative area, in the preoperative clinic, what do you know about opioids? What do you know about their risks? And what do you know about taking them and disposing of them? Fortunately, about 70%, the average correct rate was about 70% on those surveys, and that was largely around the risks of opioids, such as do they cause constipation, do they cause respiratory depression. But patients fell short on understanding what's the best way to store them, when should I dispose of them, and what other medications should I take with them. And many patients thought that it was safer. They didn't necessarily need to talk to their doctor when using alcohol, taking anxiolytics, or other potential medications that could have dangerous side effects. I think what's also striking is about 45% of patients were concerned about taking opioids. In full disclosure, this could be because we asked this question at the end of the survey, and so at that point they might have been quite concerned about taking opioids. But the extent to which we address that in the preoperative clinic visits or in our preoperative holding area is exceedingly low on the part of surgeons. So I'm going to show a few slides for some preliminary data that we've collected and analyzed. And the unit of analysis, or kind of the common metric that we use, is oral morphine equivalents. Just as a ballpark, 100 oral morphine equivalents is about 20 tablets of 5 milligrams of hydrocodone, so a standard Vicodin pill. And I want to give a huge thank you to the data core here at IHPI, who's helped us look at prescribing patterns using Optum. So this is an initial glance at what's the variation in what people get for their initial prescription after surgery. This is a cohort of all patients, and then we stratified by opioid naive, intermittent opioid users, meaning they kind of off and on filled prescriptions over the 12 months prior to surgery, and then chronic opioid users, people that filled every single month for the 12-month period prior to surgery. And I think what's striking about this graph is in the initial prescription, on the x-axis there, that's oral morphine equivalents in quintiles. So those are evenly categorized by the amount that was prescribed at the initial prescription, but only 35% of providers are prescribing within that lowest quintile. So there's a huge range, and the majority of providers are prescribing at higher levels. We performed a similar analysis looking at patients who had breast cancer using the Truven market scan data sets. And what's striking from that, looking at all patients over about a 5-year period, is that in addition to wide variation in prescribing practices, there's also not infrequent inappropriate prescribing practices, such as prolonged use, opioid misuse, indicators of high daily doses greater than 100 or more than 20 Vicodins per day, overlapping prescriptions, and the use of long-acting medications when perhaps short-acting medications would be more appropriate. We looked at this another way using Optum. So how many providers do patients get their prescriptions from? Fortunately, the majority of them only get prescriptions from about one provider, but about 20% access multiple providers to get prescriptions in the 3-month period following surgery. And the more providers that are prescribing for you, because of breakdowns in communication and challenges with care, the indicators of inappropriate prescribing go up the more people that are prescribing opioid prescriptions for a single patient in that period. So let's think a little bit about how patients go through the system when they're undergoing elective surgery. So patients come to us either from clinics. Unfortunately, some patients also come to us for trauma, accidents, and we know, and then we hope that sort of all of them end up in a pathway towards rehabilitation and getting home and getting back to their normal lives. We know about 20% of them come to us already on opioid medications, regardless of if it's elective surgery or traumatic injury. But how many patients are continuing opioids after surgery? And how many opioids on average do our patients take? I think that question is exceedingly difficult to answer because it requires actually asking patients and making sure that they remember and getting an accurate count. There's no validated instruments for that. This is an article that just came out in the Annals of Surgery in 2016 this month. And on average, patients take about 28% of the prescriptions that were provided for them. And these were common surgeries, breast surgeries, laparoscopic cholecystectomy, and hernia repair. So that suggests that about 70% of the medications that we're prescribing are in excess. How many patients refill their prescriptions? Well, a fair amount of them, about 20%. Certainly 2 to 3 is not uncommon, and then there are some outliers going into the 4 and 5 range. How many people end up being categorized as prolonged opioid use following surgery? The definition for this kind of varies, but we consider this to be anywhere longer than 3 months after surgery. It's about 20% for opioid naive patients, depending on the cohort that you look at. This particular graph is from patients with breast cancer, but it's compounded among patients who are already on opioids, and particularly among patients who are on anxiolytics and anxiolytics plus opioids preoperatively. We then wanted to look at that category of our opioid naive patients a little bit more closely. So I'm going to present an analysis that was led by Chad Brummett, trying to understand what is new persistent opioid use. So again, we classified patients as being opioid naive if they didn't have any pharmacy fills in the 11 months prior to surgery. We allowed them to have a fill within the 2 weeks prior to surgery to account for a medication that they might have gotten in preparation for surgery. But how many of them were still taking or still filling opioid prescriptions at anywhere from 3 to 6 months after surgery? And when you stratify by both minor surgery and major surgery, this is again using Optum data from here, the rates vary anywhere from 4 to 9%, but on average are around 6%. And interestingly, it's similar for both minor and major surgery. We then wanted to break it down to see, is it different by whether or not patients undergone traumatic procedures or elective procedures? And ironically, in the hand surgery population, it's a little bit higher for elective procedures, probably related to degenerative joint disease and procedures related to arthritis. So for these new persistent users, if they're about 5 to 6% of our patients, what happens to them as time goes on? Where do they go and where do they get their prescriptions from? Because typically they don't usually follow up with surgeons much after 3 months for an elective surgery. This graph illustrates kind of what happens to patients in that 6-month period following surgery. So you can certainly see the chronic users are in red up at the top, and we stratified those into high, mid, and low. And in orange here, this is now they were opioid naive, and now they're persistently using opioids at about 6 months. And you can see that the rates don't necessarily drop off. And unfortunately, looking at it a different way, we wanted to see what does it do if you look at it with benzodiazepine use. Again, our chronic opioid users, people that were taking it before and after, their levels are about the same pre- and post-operatively. But for our opioid naive patients, and these were also patients who were not taking benzodiazepines prior to surgery, you can see that now for anxiolytics, their rates also go up in the post-operative period. Which begs the question, how do we make these transitions of care, and where are these patients going to be able to get their prescriptions now post-operatively? I'll comment just a little bit on chronic opioid use and what effect it has on the post-operative period. So an analysis performed by our group led by Dave Crone, he found using MSQC data that chronic opioid use increases length of stay, it increases complications, our patients are less likely to go home, and it also increased costs of care. And here's a graph illustrating that. When you break it down by oral morphine equivalents that patients were taking prior to surgery, again, the highest group were taking more than 100 oral morphine equivalents per day, or more than 20 Vicodins per day, but clearly there's a dose response with the amount of opioid that somebody's taking prior to elective surgery. Some of this may also be borne by complications, and so we've recently looked to see what is the relationship between preoperative opioid use and the risk of complications. We chose major complications, including pulmonary failure, pneumonia, MI, VTE, renal failure, bleeding, surgical site infection, and GI bleeding. And again, you can see for our patients that are on higher doses of opioids preoperatively, their risk of complications after surgery is higher. So I'll stop there. It's kind of a lot of data, but I think it sets an important framework for what can we as surgeons do to combat this problem going forward. And so I think that so far we've been able to identify some critical knowledge gaps, both on the part of surgeons and on patients. We've identified that our prescribing is highly variable, and I think there's a huge opportunity to improve this. Unfortunately, prolonged use is common, but probably most striking is that new persistent use is, I think, an unrecognized complication. We've been able to make surgery safe in multiple domains of care, but having a risk of up to 6%, or 1 out of every 20 patients that we operate on, still requiring opioid use, still requiring opioids long after surgery, I think we can make a lot better. So on that note, I'm going to turn over to Mike to talk about what we can do in our state to improve things.
So I think why this project is different than most of the other ones I've been involved in is just right from the beginning, we were like, all right, how can we use these data kind of not to do the normal academic things, but how can we use them to make the world a better place? So we have some vision around that, and I'm going to kind of talk about it. When you think about kind of epidemics in public health, you don't usually think of surgeons or anesthesiologists, particularly not anesthesiologists. So I think we were excited to potentially have a positive impact on this problem, and I think having been born and raised here, at least by Dr. Campbell for 20 years, you start to kind of buy into the fact that our job is in many-fold, but in part is to serve the state of Michigan. We are the University of Michigan. Through kind of working in the collaboratives, many of us have spent a lot of time driving around the state, getting to know the physicians and the providers in the state. And it was clear to us that this is a particular problem in Michigan. So this is the same graph Jen showed. And I don't know, Chad, I'm going to chime in. Chad's our data guy. What are we? We're like number 7 in the country? Yeah, so opioid kind of misuse, opioid overdose, I guess opioid problems are particularly relevant in certain regions of the United States, and Michigan fits that bill. So just looking at Jackson County here, we really, it's an obvious target for us. We have friends and family there, so to speak, and we really hope to have a positive impact, there. So we have a bunch of data. What are we going to do about it? Well, we felt pretty early that we could fix this problem. When you talk to surgeons about this, they're like, at least around here, they have no idea how they write for opioids because surgical residents like Jay do it all for them, right? So I wrote for an opioid, ironically, last week. But prior to that, it had been about 5 years. So it's not kind of something. It's something you kind of outsource to the machine, so to speak. And it's kind of a necessary evil. And there's lots of pressures to write for a lot of opioids because patients you don't give them enough. They call back and they kind of make the clinic and the services really busy. But we thought this was a problem we could fix. I think we were pretty sure Jen could fix the copier and Chad could figure out what to do with the bowl, and I'll probably clean up the floor. That's all will let me do. But I think we were pretty inspired to do good work, and we focused. So I think our focus right now is this, what I consider a remarkable piece of data, and the bullet item is this: probably the most common surgical complication in the United States right now is taking an opioid-naive patient and leaving them an chronic opioid user. And just think about your loved ones who have minor surgery, hernias, hysterectomies, little things. And what a devastating complication that be, and how much that can change their life forever. And it seems kind of ridiculous, and it seems like a space where we can have a positive impact. So Chad, more than anyone, has inspired us, Jen and I, to get involved in this. So Chad is an expert on opioids. Jen and I are just kind of dabbling. But through my connections with Dr. Campbell, I thought I could help bring kind of doctors together. And Jen, all that data, by the way, Jen did all that work. She's just cranking through and kind of developing foundational data for us. But this is one thing that Chad's been doing for about 2 years, right, Chad? Through his research group, they've been having opioid drives to try to get opioids out of our communities. And it was kind of a all shucks moment. It's like, wow, that will fix part of the problem. That's actually, unlike writing a paper, that'll actually fix part of the problem. I think Jen and I found that an inspirational opportunity for the program. So this is one of his opioid drives. They've had 3, and I'll show you some data. But more importantly, this is a day where I get to pretend I'm an anesthesiologist because I showed up for like 10 minutes with coffee in my hand, smiled a lot, and then left. I took a break, yeah, and I left, yeah. So this is just a picture of some of the good work that was probably the one in the spring. So 3 opioid drives from Chad and his team have organized. This is how many people showed up. Just kind of get a sense of how many pills people dropped off. And I think kind of most relevantly here, the most common reason on the pill on the bottle as to why people had them were surgery. So the thing about chronic opioid use is if you have chronic pain, you take all your opioids. But I challenge everyone in this room, this is your homework, go to your cupboard, and when you get home today, and see if you have any opioids in your house. I bet half of you do. You might not even know it. Last night I called my dad, and I was like, hey, Dad, can you look in your cupboard? And he looked, and he had 5. He's never even had surgery. This is a 77-year-old guy. He's had stuff, right? And he had 5 bottles. He didn't know what they were. It's like, what are those? He's like, Vicodin. That's an opioid, right? Yes, they are. So, so these things are all over our communities, and the implications of that are devastating. So I think we were inspired to kind of do community outreach, which I think Jen and I had never done before. We were excited. But then, we live in this place. When I say literally, we live in this building, and in this building there's so much good work, particularly within the context of engaging with physicians. So we have great relationships with Blue Cross, and we've developed a great relationship with the state of Michigan. And then these are essentially friends and family. These are the CQIs that live in this building that focus on improving surgical care in the state of Michigan, and seem like a perfect partnership to try to make a dent in this problem. And then, literally, we're all in the same building, and that can't underscore how important that is to be here at IHPI, because why we have a potentially very exciting program is essentially about relationships and being in the same place. So it was kind of like falling off a log. So many people ask us how we've gotten funded. So for young investigators, I'll tell you the story. It's not the usual kind of way, and many of us have spent thousands of hours kind of grinding through grants. And if we had done that, we would be on our first revision of our first R01 on this problem, and we would probably start our program in about a year with about 10% the budget we need to do. So it's just not, NIH grant funding was not going to be the answer. It could certainly help. But so anyway, Chad, Jen, and I started getting excited about this problem. We talked to Dr. Campbell. Dr. Campbell introduced us to Rick. We talked to John Ianian. You're the gray hairs, by the way, John and Dr. Campbell. And Rick is kind of makes sausage, I guess is how he describes it. Yeah. And then he said he needed to talk to my friend Chris Peast at Medicaid. And within about 10 minutes, Chad had the guy stalked. And then Chad and I were standing here at Liberty Athletic Club. Jen is probably over there working out because on the weekends all 3 of us are there. And Chris Priest, suddenly Chad was on the exercise machine next to Chris Priest. And I think but the subtext here is that I think for the next 6 months, Chad and I walked around with this narrative in our head and our hand out, and telling this story to people. And these are just some of the stakeholders that we've told it to. And I think it's fair to say, besides the Office of the Surgeon General, we've had a positive response from everyone. Everyone on this list, too. It doesn't necessarily mean they've given us a pile of money, but certainly they are now partners in this story, and I think that has certainly fueled momentum and opportunities. So, but in short, we are funded from Medicaid as a Medicaid matching program to try to do good work. So this is our logo, and we put together an awesome video. So I'm going to show that to you guys to kind of tell you what we're trying to accomplish.
There was an opioid epidemic in the United States, and it shows no signs of slowing down. This is a major public health crisis. The United States comprises 4% of the world's population. However, we consume 80% of the world's opioids. Unfortunately, the United States is not better at managing pain than other countries. Currently, 78 Americans die each day due to opioid-related overdoses, comparable to 4 747 plane crashes each month. The majority of strategies focus on treating abuse rather than preventing it. But prevention is key in the fight against opioid abuse. Opioids are often prescribed for pain following surgery, but are often misused by patients to treat other symptoms, such as depression, insomnia, arthritis, headaches, and fibromyalgia. Among patients not using opioids before surgery, the most common post-operative complication is becoming a new chronic opioid user, more common than wound infection, heart attack, and blood clot. Between 5 to 8% of patients not taking opioids before surgery become opioid users chronically, even for very minor surgeries. For some surgeries, it is up to 20%. The majority of patients stop using opioids soon after surgery. However, many leave their unused opioids unprotected in their homes. These opioids get into our communities with devastating effects. The lack of education, guidelines, and safe disposal options for opioid medications further fuel this crisis. The Michigan Opioid Prescribing and Engagement Network, Michigan Open, is led by researchers at the University of Michigan in collaboration with physicians, nurses, and mid-level practitioners throughout the state, and is made possible by public and private payers. Michigan Open aims to raise awareness through education, create interventions to reduce postoperative opioid prescribing and patient consumption, and create a cycle for continuous improvement. Michigan Open aims to ensure appropriate acute pain care while protecting patients and communities. Our platform will provide practical and generalizable strategies that can be applied across the United States and a novel pathway centered on prevention to end the opioid epidemic.
We lost the IHPI logo on that. Oh, it's right there. Good. All right. Still a work in progress, but pretty tight. So a couple things. One is, what were my points? I don't necessarily remember. I think surgery, major events, major health events are huge pivot points in people's lives, and they essentially change the directions of people's lives. Major health event, particularly major surgery, is ranked as the second most stressful event in people's lives other than death of a child or spouse. So these are unique opportunities for behavioral change, or they're very vulnerable times for patients, and and policymakers, payers can't really kind of have the impact that I think we as providers can. So we're motivated to try to do this good work for all the right reasons. So my last two slides, and I'm going to turn over to Chad. Chad really is the driving force behind this, and his fund of knowledge in this space is well beyond mine. But this is just kind of just close to home. So deaths related to opioid overdose have nearly doubled in Washtenaw County in the last year, essentially, which is an amazing statistic. And Washtenaw County, don't get me wrong, it has its problems, but it's even more devastating in some of our rural counties. So within that context, this is the next pain take-back day. So I challenge everyone to look in your cupboards, and if you have any opioids or any meds you don't want, they'll take back any prescription medications. Any other rules around that, Chad? No needles, right?
No liquids, no needles.
No liquids, no needles. In about 2 weeks at Pioneer High School. So it runs for about 4 hours. It's an impressive show. We aspire to do all the things on that sign out there. Collaborate, for sure. We aspire to have these essentially at every hospital and every community in the state over the course of our relationship. That's collaborate on the sign I'm going for. The next one is evidence. So we've already developed some, but we aspire to develop best practice around perioperative opioid prescribing. So how many opioids should I write for my lap chole? Right now, at the University of Michigan, we write for somewhere between like 30 and 100. Vicodin, and our patients probably take 7 or 8 of them. So we don't have enough data to really know what that sweet spot's going to be, but that would be the evidence side. And the third thing would be impact, and I think we're very focused on that, which makes this a unique project. Positive impact on the health and wellness of society within the framework of being just nerdy researchers who kind of don't usually do very much. So that's our work. Chad, why don't you come up and answer questions? And yeah, please pepper Chad with really hard questions.
Why don't you guys sit here in case I get any really hard ones?
All right.
So before we turn the screen off, I'll circulate this widely, and we do a lot of social media around this. We have, actually, before I forget, Kristen and Mike, will you guys stand up real quick? Yeah, that's, I mean, like with your legs, like stand all the way up. So it's Kristen Bennett, she's my admin, and Mike Sari, one of our research assistants. And two of them have really taken charge of this. Kristen from the very beginning, Mike's gotten more involved in the last year. But they have really been the charge and the force. Yeah, okay, you said that. So they've really been the charge and the force behind this in terms of organizing. And the thing Mike didn't mention is that we're already in early conversations with at least 4 and maybe 5 sites through the surgical collaboratives to spread this in the spring. And then I really aspire that I think that in a year's time, we should be looking at least maybe 30 sites in the state of Michigan and really trying to have wide impact. We've got a group at Waljee in the anesthesia department there that is already taking our platform. Kristen's written a beautiful SOP on how to start your own opioid drive in your own community. So if you have friends or family, we don't own this, we don't want to hoard it, we want people to use it. And that information is there. And then we just got a group at Wake Forest that wrote me last night and said that they wanted to do their own drive. So this is the kind of thing that really engages people and makes people excited. But the one thing is, despite all the social media, despite all the emails, nothing quite works like you emailing someone you know well, or a group that recognizes your email, because we all get too much email. I'm going to ask that we turn this off so that Mike and Jen don't shine on the top of their head there. But we'll take some questions. Does anybody have any questions? Yeah, we'll be in the back there. Do you want to? Do we have a? Are you turning on the mic there?
I was going to turn this off.
Sure. Oh, I'm sorry. I can't do that. Oh, I'll look back.
You know, if you just want to, you can just say the question out loud, and I'll repeat it. Is that cool? I'll repeat it in the mic so that the machine can get it. Is that cool?
Okay.
All right.
Hi, my name's Anna Fernandez. Oh.
Thank you. My question is, I was curious if you looked at the data to do anything like a profile analysis to see which patients may be the ones that are most likely or more likely to become opioid users who were previously opioid naive.
Yeah, so that's a really good question. So in that data that are pending review right now, the 6%, we did look at, we used ICD-9 codes. That was from a claims database, it's from Optum. And there are things that come out as significant, but the adjusted odds ratios range from like 1.2 to 1.8. And I think what it really tells us is we don't know what's going on. Certainly from our clinic side, on the chronic pain side, Jenna Gessling, who is a K23 funded researcher in our group, has been doing a lot of work on affect and persistent opioid use, shown striking data with respect to depressed patients in persistent use. The issue, I think, with ICD-9 codes is, while we might be picking up the most extreme patient with respect to depression, I don't think we're really capturing that scope. And certainly within my research, I think that middle ground, that piece that may be like just subclinical, is still really important. And it doesn't also capture sort of that reactive sort of mediation piece of what happens after surgery with respect to change in mood, change in anxiety. And so Jen and I are in the midst of resubmitting an R01 that will use a couple of the other sites to get some diversity of care, diversity of practice, but doing some more granular phenotyping on patients and getting some prospective data. Because the more I look at the claims data, the more I'm convinced that the claims data aren't going to tell us the patient at risk, that we're going to need something more granular. And I don't propose that we're going to have to ask every surgeon, ask every patient lots of questions, but I think we need a little bit of understanding. And so we're casting a fairly wide net, although we do have some specific hypotheses. Do you have something in particular that jumps out to you or something you'd want to share?
I was actually curious about their previous substance use.
Yeah.
In other types of substance use, if that was.
Yeah, so that is substance use is in Optum. I don't know how good the data are, but they are there, and it was significantly associated, but again, didn't jump off the page. I think Brummett helped a lot. Brummett Nalamathu helped a lot with that analysis, and he finished and kind of looked at me and goes, so basically, we don't know, and I think that's just another sort of driving force, for why we're so passionate about this, because ultimately, I don't think biggest claims data, and I think the unique structure here at Michigan through the CQIs is so well poised to actually address that outside of sort of the classic ivory tower model. Other questions? Yes.
Hi, I'm Angie Perez-Martinez from the Center for Opioid Research. Oh, thank you. Hi, I'm Angie Perez-Martinez from CHART at U of M, and I am here to represent the Washington Health Initiative
Angie.
Opioid Project.
We know you only by email to this point. That's great. We get lots of emails from you. Great.
So my question is, why is Michigan so high in terms of the opioid epidemic? What is different in Michigan than in other states?
That's a really good question. I'll do my best, but I would imagine you've thought about this. Actually, probably don't go away because I'm going to want her opinion. So you've probably actually thought about this more than I have. But there was that article that just came out where they looked at sort of different markers, different measures of how well states are doing with respect to managing and tracking opioids, and we failed in every category, not just in a few of them, but like literally in every category. And I can't really. Do you guys have any further thoughts? But I think we've got a big F with respect to how we're managing things. As to why Michigan in particular, I don't know. If you look at our state, we've had some tough times. I think that's definitely a factor. Certainly, we think vulnerable populations, especially when you think about socioeconomic factors, are important. When you look at that state spread map, the Jackson area, you go up north to some of those rural populations over in Port Huron. Jen's always claiming that there's lots of patients coming in the trauma burn service from that Port Huron area. We're seeing it, but I think the socioeconomic impact of Michigan, our state's had some big hits over the last few years, and I don't think that's helped us. Do you have thoughts?
Sorry, I took the mic from her.
Great. If you have thoughts, let us know.
Yeah, because I do. So I was going to say the socioeconomic issues that Michigan experienced in the Great Recession before other states, I think had a big impact. But the other thing is, infrastructure-wise, we know a few things that work to do better regulation for opioid use, and there's not really political will or funding, which is linked to political will, to fund those kinds of infrastructures here in the state.
Such as like prescription drug monitoring programs, is that what you mean? Or?
Yeah, that, or just philosophical desire to even have regulation.
Sure.
Because of the way our state operates. So I think that's part of it.
MAPS just got a big bolus of money to revise itself to try to hopefully become more useful, but there's no doubt. I was in the hospital yesterday, saw a patient that was getting 720 of the 10 milligram hydrocodone, 325 acetaminophen per month, and then another 180 of the 60 milligram Oxycontin per month. So he should, if taking all those, be seeing Dr. Englesbe for a liver transplant just based on the acetaminophen load of 24 tablets per day. So clearly MAPS programs don't have an effect, and it was a single provider, 6 consecutive prescriptions. How the pharmacy doesn't catch that, we have to start to take some ownership there, right? So, it's a wild world out there. In the pain clinic every day. We MAPS every patient that comes in our clinic. It's certainly something we're very interested in within the surgical space, is how to use our prescription drug monitoring programs to make them useful and applicable to perioperative care. Because right now we're writing post-op scripts and we don't actually know whether the patient's already on opioids. Don't know.
Hey, Jen, go ahead. I'll wait. Yeah. Steven, you go, Steven.
Well, first of all, I want to applaud your efforts in this presentation, and this is so in line with a lot of the work that we're trying to do at the community level. So my name is Steven Strobe. I'm a clinical associate professor at the School of Nursing and the Department of Psychiatry. I also got tagged in a volunteer capacity to be the co-chair for the Washington Health Initiative Opioid Project. It's modeled after Project Lazarus, so this is an evidence-based, community-based effort to try to constructively address the issues around opioid misuse and related overdose deaths. One of the key in that model, one of the key factors really is around professional or provider education. And so what you're doing here already at IHPI is absolutely fundamental to this work. And that in particular, when we look around the country and see how many communities have been devastated by the opioid crisis, by the opioid epidemic, when I come here, I'm reminded of what it means to be here at the University of Michigan. We had a stakeholders meeting last Friday for the Washington Health Initiative, and the Opioid Project is one of the leading projects that's associated with that. And the level of investment that's being made currently by the University of Michigan, as well as the St. Joe's system, is really quite impressive. But a community-wide effort means just that. It can't be providers alone. What is it that we're doing at the community level to be able to inform individuals, families, treatment providers, education across and throughout the community? So I'm hoping that, gee, this serves in part as kind of a speed dating opportunity for all of us. Like, oh, I've heard of your work, I know what you're doing, and to get a chance to meet and to also know what each and all of us are doing, and to try to aggregate those efforts so that we can have a more thoughtful, planned response to this. So I encourage you, I'm hoping that as a result of this, that we start to make a lot of connections with one another. A couple upcoming community-based events are, we've been invited to present at the Bright Nights series, which is hosted by our own Department of Psychiatry, and it's at the Ann Arbor Public Library. This will be on the evening of Tuesday, November 15th, and then the following week on Tuesday, the Dawn Farm Education series as well. So it may be possible that we're probably going to highlight a couple of the initiatives, like the training of law enforcement agencies and the provision of naloxone for opioid overdose reversals. And we may even have a take-back event at one of these programs as well. So thank you so much for the work that you're doing. This is model. This is a really important model. As you look across the country, if there is any place where an initiative and an effective response to the opioid crisis can be generated, where else would it be except here? So we need to think about what's possible and what our responsibility is in helping to address this constructively. I applaud your efforts and thank you so much. And from now on, we are forged partners.
Awesome.
Well, I know I speak for Chad and Jen. We're excited to partner also, and the community outreach stuff is pretty new to us. So we could use your mentorship, but we can bring maybe a little extra energy and fuel. So
we'll
super
learn
excited.
Together.
Yeah.
Other questions? Yeah, Aaron.
Super.
Thanks. So Chad, as you learn more about how to predict patients that will become, chronic users from behaviors and other clinical factors, what do you know from your other work on someone's genetic predisposition to get?
We know nothing yet about genetic predisposition, but we're really excited to have the consent available to actually start to merge these data. The Michigan Genomics Initiative has prospectively consented patients to the use of claims data for future, and we're hoping to work with Medicaid and Blue Cross Blue Shield to bring that data in to actually sort of replicate the analysis that we have pending, but now to look to do genome-wide association to see whether there's any genetic factors, both in terms of consumption, but then also persistent use, which I think have different sort of theoretical underpinnings. Ultimately, I think the reason we're focusing on these sort of 85% of people who are opioid naive to start is because I think we just have to sort of shepherd them through this process, right? And I think while we talk a lot about how surgeons need to appropriately prescribe, I think anesthesiologists and pain physicians have to embrace the opportunity. So in my pain clinic, if Mike's struggling to get somebody off of their opioids post-operatively, I think having them come into a board-certified pain physician and be evaluated and consider other options, that's really, we need to sort of join up. And it's challenging because we don't have great access models. It's not really easy for me to leave a clinic space available, and yet we need to see that patient. We need to give patients back to their primary care physician in either a better shape or at least at most as good as they were when they came in for surgery. The idea of taking an opioid tolerant patient and giving them back 200% more tolerant, or even worse, taking somebody who was not taking opioids and handing them back to the PCP, now with surgical scars, or something that they can point to and say, this is why I hurt. And then the PCP is just kind of handcuffed. They almost feel locked in to continuing to prescribe. We need to get away from that model. So I hope we can predict, and I hope we can determine those that need more and less. But I think ultimately there is going to be a practical piece of this that will go outside of my sort of traditional research thinking. Yes?
Do you happen to know that 5 or 6%, how many of those prescriptions are being continued by primary care physicians versus ER physicians?
Right. So how many of the scripts of the 5 or 6% are from a primary care or ER physician versus surgeons? We're just starting that. Jen's been working really well with we've been meeting with the MVC folks and working on NPI numbers. May in the back, or she was in the back, she's been working through, here she is, hi May. May's been working hard to look at NPI numbers. The claims data sets, I think, are going to be a little thin in that respect because we've got a lot of people who have had a single prescription, right, or getting it from 1 or 2 providers. I think ultimately this is where we have real value with the Blue Cross Blue Shield data because that transition of care we think is really important because it's more than just how many of them are being from PCP, but is there a time point where the surgeons are effectively handing this back to primary care physicians or where patients are now no longer seeking care from their surgeon? It's a critical piece because that message and that education it needs to be targeted appropriately to PCPs to ensure that they're empowered to, again, just like they would in the pain clinic, get people off opioids. Just because you have pain doesn't mean you need opioids. I mean, the fact is that there's just no good data. These really are effective for chronic long-term use. And our surgeons and our primary care physicians don't yet feel empowered to say that. They're starting to.
And just to chime in, if you know any primary care physicians who maybe have some expertise in that space, just let us know. Because we could use some help. So that's her, by the way. It's kind of a joke. So. Hey, I'm going to ask Jen a question. Jen, tell me about what can we do with our opioids and the little kind of experiments we did over the summer about opioid disposal.
Sure.
What the students do.
So when we were putting together kind of what our columns would be in terms of the work plan for this project, one of them was, understanding opioid disposal. So I went and I was like, well, I guess I'll figure out like where I'm supposed to take my opioids. And after about 80 clicks on the DEA website, I actually couldn't figure it out. And I'm not the most like tech savvy person, like I'll be honest. But I was like, well, so if I was in pain after surgery and I'm tired and I've been up for 4 days straight after my hysterectomy or whatever it was that I had, I probably can't drive because I'm on opioid pain medication. So how am I going to get to the sheriff's office, assuming I could figure that out in the first place, to dispose of my opioids? So I think that just compounds the problem. So when we think about, our elderly patients or our patients that don't necessarily have access to this, or patients that, may be in a vulnerable position and perhaps they don't really want to go to law enforcement for whatever reasons kind of underlie the stressors in their community. I think we have a big opportunity that we can change that. Part of it is pill drops, but that's just kind of at a single point in time. My hope is that, kind of one day we'll see, more receptacles around our care facilities and our clinics and our emergency rooms where people can come back with their opioids at their first post-operative visit if they're not using them. And then to highlight kind of what our students did over the summer, Rena, who's back there, you can raise your hand because you did a ton of work on this summer. Rena led some students this summer to call every single place in Michigan that receives opioids. And it's pretty striking that many of them didn't necessarily know that they were supposed to take back opioids. A lot of them said, well, I guess we take back liquids. I'm not 100% sure about that. Some of them didn't answer the phone, which was interesting, particularly because some of those were law enforcement agencies. And so I just think that it just highlights the fact that there's tons of room for improvement here, and perhaps a lot of policy work and areas around legislation that is not anything I have experience with, but would be interesting to kind of get in that avenue in this space.
And I'll say that since the beginning, and my team, many of them are here, can attest this, we've always said that this is like a really good community service opportunity to do these pill drops, and we hope that we have to go back to like flipping burgers and grilling sausages as our way to give back to the community, because ultimately this becomes a non-issue, right? You should be able to easily drop your pills. We actually are leveraging our newfound interest at an institutional level. We're going to be meeting with folks fairly high up at the institution on Friday to try to get buy-in for Michigan to become a DEA-approved take-back site, and then work through novel models to really target a surgical population. And so I think we don't want it to just be like we take them back and here's the 4th floor of Taubman in the very middle that's the hardest place to get to, but really something that's very practical. And we're going to pilot some, there's some innovative stuff out there. Caitlin's done a great job of looking through our Caitlin Ham in the back is our new project coordinator for Michigan Open. You stand up just so people can recognize you. So Caitlin has been working hard through policy and looking at innovative ways that we can create care pathways that maybe even make it so you don't even need to come back to the hospital to drop your drugs, but that this just becomes part of easy care, that we make this really easy for people. We've got about a couple more minutes, and then I know people have meetings, and we know you're taking your time. We really appreciate your time. So do we have one more question? Yeah.
Hi, I'm Tom Bridger, pharmacist at Penguin Medicine Clinics. So I'm curious to learn a little bit more about how MAPS has been engaged. I previously worked as an intern at local pharmacies years ago before pharmacy school, and it's evolved a lot over the years. It's much more available as real time. And I'm curious to see what is, if you're available to know the utilization rate, that when patients have certain care, they'll have a provider that prescribes it, a pharmacy that dispenses it, and then if others are involved as well. But do we have any data on the utilization rate of how often MAPS reports are run, and to see how involved or engaged many players in the patient's medical care are involved?
For surgery, I'd say almost never. Right, I'm not being rude here. I mean, like, I'm just saying it's just not part of our care pathway, right? And I'm in a tertiary care pain clinic. We see people for pain, and I can say that it's only in the last 2 years that we really have formalized our MAPS process. But even this weekend on the acute pain service, I'm a board-certified pain physician, and we missed somebody, and I realized it days later that this patient went into benzo withdrawal and was on opioids, and had I done a MAPS, I would have known that they were also taking benzos and hadn't reported their benzos, right? Like, there are things that we can just do better. I will say, though, I hope that Laura becomes ready to make the process easier. There's a lot of sensitivity around the data. There's a lot of want to protect that data, but not just for pure research purposes, but from an implementation and use perspective. I really hope that Laura is ready to make this easier. Laura's not a person. Laura's a regulatory agency. Just I'm not picking on any one person. So I hope that answers your question. But no, in terms of hard data, can't give it to you. Someone else in the room might be able to.
Is there any movement to have that integrated in the EMR systems?
Not at the moment, because the legislation that binds the MAP system currently, that is state legislation, wouldn't make that easy yet. But my hope is that politicians are maybe getting a sense that we need to change policy to make things a little bit better. And I think that's one thing that's really good about this program, is I think we have the ear of politicians right now, and can leverage that to make things better and practical. Thank you very much, everybody. Really appreciate your time.
Yes.